Coronary artery disease is still one of the leading causes of death in most of the world. This is also one of the reasons we chose this topic as one of the important issues that we're going to present in the forthcoming review journal of the Hamdan Medical Journal. My name is Thomas Binder, and I'm going to present to you this edition and also give you a brief overview of what will be in this journal, and at the same time give you a brief overview of what is new in cardiology with respect to coronary artery disease, and also show you who the players will be in this journal. First of all, Professor Winfried Merz. He's from Heidelberg. He's one of the leading figures dealing with epidemiology, risk, and prevention in coronary artery disease. Then we'll have Dr. Gültekin from Istanbul, a young but very ambitious and very knowledgeable colleague who will present imaging as his main topic. Then finally we'll have Dr. Delikat, who is from the University of Vienna, where he is co-head of the invasive laboratory dealing with coronary angiography and PCI. And then finally we'll have Professor Günther Laufer, who heads the Department of Cardiovascular Surgery, also at the Medical University of Vienna. But let me just start by just giving you a bit of an overview of what coronary artery disease means, and maybe show you how important this issue actually is and why, as mentioned previously, this is such an important issue. Well, first of all, who is actually involved? What are the countries and what are the people, or what are the patients that we have? Well, basically, it is every patient. It is not only the rich, it is not the poor, it is the high, the low, and the middle income, and it is many, many countries all around the world. And if you look at just the population of the US, approximately half of the men have some involvement of coronary artery disease, while approximately 20% of women have coronary artery disease. So a very, very large figure, and if the patients don't die from coronary artery disease, it at least plays a role in their well-being and maybe also as a cofactor of their survival. Now, one thing which is very clear to us if we look at the data presented by the World Health Organization, there's an increase in coronary artery disease. This is the projected increase from 1990 to the year 2020. And what we see here is that basically it is both the developed and the developing countries which have a problem, and even more so the developing countries. So this is a problem that you will see in countries where the economy is now growing and where we have a number of different lifestyle changes which will later affect the incidence of coronary artery disease. So another problem we are faced with is that especially women are affected, even more so in the developing countries. Now, the mortality of coronary artery disease is very high, as I mentioned previously. Approximately a third of patients die of coronary artery disease. So this is very high. And if we focus just on the trends in the Arab world, then the trends are very clear. It is a trend towards younger patients having coronary artery disease. We see coronary artery disease in juvenile patients already, and there's a rapid increase in the prevalence, basically due to obesity, as we heard from Professor Ludwig before, and diabetes, the urbanization, sedentary lifestyle, smoking, and lipids. Those are the well-established risk factors that have to be tackled. Just one slide showing you the problem of obesity. This is again from the World Health Organization, showing that it is, of course, still the Western world which has a problem, but followed also already by the countries of the Middle East, for example, and Africa. So there is an increase in this problem with respect to obesity, and this just mirrors the problem we have with coronary artery disease and the incidence and death. What are the other risk factors? Just to briefly go through them. It's smoking, obviously. It is diabetes. It is hypertension. And it is lipids. They're all kind of interconnected and are a very big problem. Aside from that, there are risk factors which might not be as well as known to the general population, which are chronic kidney disease, a family history of coronary artery disease. Genetic factors play a very large role. We know that now. Inflammatory markers, vitamin D plays a role, and Professor Merz will be lecturing on this, or at least reporting on this in his review. And then finally, interleukin-6. So there has to be preventive strategies. We now have to use this epidemiological data, and we have to target exactly these risk factors: the sedative lifestyle, information to the people, and we have to screen the patients to try to detect the coronary artery disease at an early stage, because in this stage we still have a chance to prevent myocardial infarction. This is where we have to really focus to perform preventive measures, primary preventive measures. With respect to imaging in coronary artery disease, there's been a lot of developments here, a lot of technical developments. The industry has really given us tools with which it is very easy, as a matter of fact, to detect coronary artery disease. But detection alone is not the only thing we're looking for. We're also looking for more information that can help us to decide what we should actually do with these patients. Let me just first turn to echocardiography. Echocardiography is obviously a mainstay. It's been around for 20 years, but there is no still stand here. Echocardiography has really evolved. This is just an image to show you how superb the echocardiogram can be. You can even see the fibers of the heart if you look exactly. And the information we can obtain from echocardiography are multiple. Not only can we look at left ventricular function and determine if the patient still has a normal function of the heart, we can also look at regional wall motion abnormalities, for example, to diagnose coronary artery disease. This is an example of a patient who had an acute anterior infarction, where you can see an infarct right here at the apex of the heart. This would be the left ventricle. So the diagnosis of acute myocardial infarction, but also chronic myocardial infarction, is very easily possible with the help of coronary artery disease. This can be combined with stress echocardiography, which allows us to detect ischemia, similar as you would do, for example, for a treadmill test. And this information is extremely important because it provides prognostic information and it helps us to target therapies. There are new advances in echocardiography which are also coming along, which are very important. Here is an example of 3D echocardiography. We now have transducers that we can put on the chest, which actually provide real-life or real-time data to display, for example, the mitral valve. The mitral valve, which also plays a role in coronary artery disease. Why? Because if you have an infarct, you might have some form of disturbance of the valvular geometry, which can lead to mitral regurgitation, a factor which greatly influences the prognosis of patients with infarcts if they also have additional regurgitation. Another very fascinating new development in echocardiography is the so-called technique of Speckle tracking, which allows us now to obtain new functional information. Not only can we look at the volumes of the heart and quantify ejection fractions, but we can even see how the myocardial fiber actually contracts. And this information can be obtained by tracking the little speckles. Those are the little white dots you can kind of see here on the echo image, and comparing how they move with respect to each other. And in the end effect, we can calculate what we call deformation. And this deformation tells us a lot about how the myocardium is doing, not only globally, but also regionally. And what we then get is something like this here, which is a kind of a bullseye display, which gives us a representation of contractility in different regions of the heart. Why is this important? Because this is a tool that can help us to detect problems of ventricular function at a very early stage, before we even see some form of regional wall motion abnormality or a drop in global left ventricular function. So this will play a very important role, and there's a lot of developments here, and I'm sure that this is something that will come more and more into clinical practice in the following years. Computed tomography, well, you're all aware that we are now able to look at the plaques and at the coronaries also with computed tomography, something which is very difficult technically. Why? Because the heart is moving, and we have to be very quickly with our image acquisition to be able to visualize the coronary arteries in such a way that we do not have artifacts. But it can be done, and we can not only look at the coronaries and see if there is a narrowing or not, but we can also quantify the degree of calcium which is in the coronaries, which has a very important prognostic factor. So in summary, this is a technique which obviously is still in development, has its role, and will certainly complement coronary angiography, which which I must also mention, will never replace coronary angiography, but it will play a very important role in certain aspects. In the journal, we will also report on the advances with respect to the radiation problem. As you can be, of course, aware, there is a lot of radiation associated with computed tomography, but there are a number of techniques and technological advances which are targeting this and which would make this technique more available as a screening method for patients who are at risk. This technique can be displayed in various ways. Here's a fascinating image of a three-dimensional display of the heart showing the coronary arteries and demonstrating to you how good the resolution actually is and how we are able to now look at even the smaller parts of the coronaries. Now, we have to remember, computed tomography opposed to coronary angiography has a certain advantage. We can really look at the walls of the coronaries opposed to the lumen. So there is certainly additional information here, and CT will play a role and already does play a role. What about heart catheter? It's a very, very old technique, one might say, but nevertheless a technique which will still be here in the forthcoming years and decades, but with the adjunct that we are now able not only to provide better images, but also we are now able to use the technique of coronary angiography to look at the coronaries. We've done that previously with intravascular ultrasound. This is a topic which will also be part of the journal, but we are now able to use a new technology which is called optical coherence tomography, which uses light similar to the way we use ultrasound, in the way that light is reflected and computed to generate an image from within the coronary artery. So you have a catheter, you've got the system installed, and you, during a pullback mechanism, record the image over a certain length of the coronary arteries, and you get an information about the composition of the wall. You get an information about plaque composition. Now, this is such an example. You can see here, this is the catheter right here at the center. Then you have the lumen, and if you look right here at 11 o'clock, 12 o'clock, you see that there is a plaque here. Now, the plaque we can see from a contour with a coronary angiogram as well, but what we see here is we see the composition. And why is this so important? Simple, because the composition of the plaque is something that plays a very important role with respect to the risk of developing an infarct and also with the potential and the prognosis if we stent this stenosis. So this information certainly is important. Here's an example of such optical coherence tomography image in a patient with a stent. You can see the stent struts here, and you see how nicely the stent is deployed, which is a very important question that we always ask if we perform interventional cardiology. Is the stent really in place? Do we have struts which are somehow reaching out and are in a way a nidus for a thrombus formation? So here you can see in this case that the stent is very well deployed and everything is fine. Of course, we'll be dealing with percutaneous intervention and with a wide array of new stents which are now coming along, and also with the problem of now treating more and more complex lesions, and to also show you that the new stents have now a lower risk compared to the older stents with a much better outcome, which has changed the indication for PCI to a great extent. And what probably was an important breakthrough was the early studies in the I would say 90s, which showed that PCI is the method of choice in the setting of acute myocardial infarction. This is standard of care. This is what really changes prognosis, because the earlier we are able to open the vessel, the less myocardial damage is performed and the better the prognosis of the patient is. So the strategies in acute myocardial infarction now focus towards bringing the patient into the cath lab as quickly as possible to reduce the so-called ischemia to open time and the door to needle time and all the different intervals which play a role. So this is an important factor. And of course also new thrombolytic agents which will also be discussed in this review journal. What are the indications? What are the other indications for PCI? Well, aside from acute myocardial infarction, it's simple lesions. If ischemia is here, it's also complex lesions such as left main occlusions, left main stenosis, bifurcation stenosis, and chronic total obstruction. Here you have a chronic total occlusion, which we can now reopen with a number of different techniques, different wires, with rote ablation and many other methods. Here is an example of a bifurcation stenosis where we can use techniques such as the crush technique, where we put two stents which are kind of interlinked. Here we have a main stem stenosis on the left up here, and here is a very simple lesion right here in the right coronary artery. So all of these are now targets for intervention, and I'm sure as new technologies come along, these indications might be expanded. The issue of stents is a very important one. Why? Because we've had a breakthrough with the development of so-called drug-eluting stents. What are the drug-eluting stents? Well, they're stents which have a substance that is antistenotic, which prohibits proliferation. And when we deploy the stent, this substance is brought into the coronaries and prevents the problem of restenosis, a problem that was very high, somewhere in the range of maybe 30 to 35% in the early 80s. At the time, we did not have the drug-eluting stent. So this problem is now something that is not solved, but at least drastically reduced. And the drug-eluting stents certainly have an advantage to the bare metal stents. But there is more coming. The next kid on